Hello everyone. Today we are going to discuss Chapter 4, Disorders and Diseases of the Skin. So if you are in aesthetic school, taking refresher aesthetics courses, or simply just want to learn something new, the way that we break down Chapter 4 might be helpful. There are 14 objectives in Chapter 14, so this may be a quite lengthy video. The 14 objectives are: number 1, explain why knowledge of diseases and disorders is valuable for an esthetician. Number 2, describe how an esthetician and a dermatologist can work collaboratively. Number 3, identify the differences between primary, secondary, and tertiary lesions. Number 4, recognize skin changes that could indicate a type of skin cancer. Number 5, describe the types of acne. Number 6, describe the symptoms of polycystic ovarian syndrome, or what we call PCOS. Number 7, list common vascular conditions or disorders. Number 8, identify pigment disorders. Number 9, describe the different types of dermatitis. Number 10, identify the types of hypertrophies. 11, define 9 contagious skin and nail diseases. 12, identify 2 mental health conditions that may manifest as skin conditions. 13, recognize common skin conditions related to skin diseases and disorders. And number 14, explain 5 sudoriferous gland disorders. Objective number 1, explain why knowledge of diseases and disorders is valuable for an esthetician. So skin disorders and diseases are fascinating and complex subjects. Estheticians must be knowledgeable about skin disorders and diseases. As an esthetician, it is not within your scope of practice to diagnose skin diseases, but being savvy enough to recognize common medical conditions can help you work with clients more effectively and safely. Estheticians should study and have thorough understanding of disorders and diseases of the skin because you want to be able to recognize a potentially contagious skin disorder to help stop the spread of infection. You will also help individuals that have skin problems and have been affected emotionally by dealing with such a visible problem, and learning when to stop a service and refer a client to a medical professional may actually save their life. Objective 2, describe how an esthetician and a dermatologist can work collaboratively. Dermatology is the branch of medical science that studies and treats the skin and its disorders and diseases. A dermatologist is a physician who treats these disorders and diseases. Recognizing skin disorders and diseases is important for the protection of both the technician and the client. Estheticians may not perform services on clients who have contagious or infectious diseases. Dermatologists, physicians, and nurse practitioners are qualified to diagnose skin problems. However, once diagnosed, estheticians can help clients with many common disorders and conditions such as rosacea, acne, and hyperpigmentation. Caution and strict infection control practices are imperative when working with skin disorders. Knowledge of skin conditions that contraindicate or prohibit a treatment is also necessary. Objective 3, identify the differences between primary, secondary, and tertiary skin lesions. You do need to understand and write down in your notes what a lesion is. And a lesion is a structural change in the tissues caused by damage or injury. So any mark, any wound, or abnormality is described as a lesion. There are 3 types, which are primary, secondary, and tertiary. Let's break them down. So again, we have primary, secondary, and tertiary lesions. And we are going to start with breaking down our primary lesions first. So, what is a primary lesion? A primary lesion are lesions in the initial stages of development or change. Write that in your notes. A primary lesion is a lesion that is in its initial stage or stage of development or changes. Primary lesions are characterized by flat, non-palpable changes in the skin color or by elevations formed by a fluid in a cavity, such as vesicles or pustules. We're going to start with what a bulla is, okay? And you are able to find a table of all the primary lesions if you're following along in your textbook from page 124 all the way to 125. Okay, so we're going to start with the bulla. So a bulla is described as a large blister containing a watery fluid. It's similar to a vesicle. Bullas are blisters. They do require medical referral. Examples of a bulla may be contact dermatitis, possibly a large second-degree burn, bulbous impetigo. Those would all be considered or fall under the description of a bulla. So on the low end, we call it a bulla. High end, we just call it, high end, we call it a bulla. Low end, we call it a large watery blister containing watery fluid. Next, we have a cyst or a tubercle. These are closed, abnormally developed sacs that contain pus, semi-fluid, or morbid matter above or below the skin. A cyst can be drained of fluid and a tubercle cannot. Either way, both of these require medical referral. Examples of a cyst in skincare may be a severe acne cyst that you sometimes find or feel underneath the surface. Okay. Next, we have a macule. So a macule is described as a flat spot or discoloration on the skin. Examples of a macule may be an age spot or a freckle. So again, make sure that you're writing down the characteristics of these lesions because you may see these on your state board exam. You may see them on your chapter exams for your class or your course. And then you also you want to be able to identify these in your treatment room. Next up we have is a nodule, okay? Nodules are just a solid bump larger than about 1 centimeter that can be easily felt. As an esthetician, we can't do anything with nodules. We have to refer them to a physician. An example of a nodule would be swollen lymph nodes or someone that has rheumatoid arthritis who may have rheumatoid nodules, okay? And you can also take a look at the graphics here and see how each one of these primary lesions, how it actually affects the skin from the epidermis to the epidermis, okay? If you have questions, make sure that you drop us comments below. Next up, we have papules and pustules. These are common. We see these in the treatment room all the time. A papule is just described as a small elevation on the skin that contains no fluid, but may develop pus later on. So papules can turn to pustules. Examples of papules and when we will see these would be if a person has acne, a wart, or maybe an elevated nevi, which is basically an elevated birthmark. A pustule is also something that we see in the treatment room. It's raised, it's inflamed. It's a papule with a white or yellow center containing pus in the top of that lesion. And again, so examples that we may see are found with papules or are with someone that may have acne. Also, if a person is diagnosed with impetigo, they may have pustules, and then you may also see folliculitis in your treatment room, which again is an example of, can be an example of a pustule. Next, we have a tumor. So notice how that tumor has that dark part around it. Tumors are abnormal masses varying in size, shape, and color. Any type of abnormal mass is not always cancer, but they do require medical referral. The textbook does give us an example of a tumor as cancer. Again, not all tumors are cancerous, but they do require medical attention. Next, we have a vesicle. So vesicle almost looks like that bulla that we saw on the last slide. The only thing is vesicles are smaller. So a vesicle is basically a small blister or sac containing clear fluid, and it may lie just within or just beneath the epidermis, okay? If you notice that this vesicle is not traveling down to the true skin or to the dermis, these do require medical referral if the cause is unknown or untreatable with over-the-counter products. An example of a vesicle that the textbook gives us is poison oak or poison ivy, okay? And then we have a welt, okay? And a welt is basically described as an itchy, swollen lesion that can be caused by a blow to the skin, maybe a scratch to the skin, or maybe a bite from an insect, or urticaria, which is basically a skin allergy, or from the sting of a nettle, maybe a bee sting, mosquito bite, breaking out into hives. Welts usually resolve on their own, so typically medical attention is not required, but you should refer to a physician anytime that a welt lasts more than 3 days. Next, we have secondary lesions. So these secondary lesions, if you're writing and taking your notes, secondary lesions are characterized by piles of material. Write that down. Secondary lesions are characterized by piles of material on the skin surface, such as like a crust or a scab, or by depressions in the skin surface, such as like an ulcer. These may require medical referral, and so we're going to look through all of these lesions. You can find this table in your textbook if you're following along on page 126 all the way through 127. There are 7 of them that we're going to cover, and we're going to start with what a crust is, okay? So as you can see, this crust, it's not affecting any of the deeper layers of the skin, completely on the top of the epidermis, and is described by dead cells that form over a wound or blemish while healing. It's an accumulation of sebum and pus, sometimes mixed with epidermal cells. So an example of a crust is basically when you have a scab or a sore. Next, we have an excoriation. So I don't really like this picture that Milady gives us. I do encourage you to go and find, go Google, research pictures of excoriations to the skin. But basically, an excoriation is a skin sore or abrasion that's produced by scratching or scraping. The textbook gives us an example of excoriation as like nail cuticle damage from like biting the nails. So it's basically like lifted skin, a small divot in the skin. It may be just basically not a smooth surface. If you've ever seen someone that bites their skin, you bites their nails, you'll notice that the skin around their nails and their nails are also jagged. The skin is uneven, it's textured. So that would be an example of an excoriation. Next, we have a fissure. So if you take a look at this example of a fissure, you can see that this fissure, it actually affects the epidermis all the way down to the dermis and even possibly to the hypodermis. So a fissure is just basically a crack in the skin. It penetrates down to the dermis. So the example is maybe chapped or cracked hands, chapped or cracked lips, chapped or cracked feet. Okay, so those are that's what a fissure is. These can be painful. Again, medical attention is required because these fissures do tend to affect the dermis, and we can't do anything to the dermis. If your clients have chapped lips or hands or feet, you can recommend various products, but there's not much that we can do as an esthetician to treat these other than something topical. no medical attention. Next, we have a keloid. So a keloid, if you can see how it looks on the surface of the skin, it sits on top of the epidermis. A keloid is basically a thick scar resulting from excessive growth of fibrous tissue. So keloids will form along any type of scar for people who are susceptible to them. Okay. Next, we have scales. So scales are also secondary lesions. Scales are thin flakes. They can be dry or they can be oily, but they are epidermal flakes. Examples of scales or scaly skin could be associated with like having excessive dandruff, or if your client has psoriasis or maybe even seborrheic dermatitis, you may notice scales on their skin or their scalp. Then we have a scar. So on the low end, we call it a scar. On the high end, you call it a cicatrix. And basically, the description of a scar is a slightly raised or depressed area of the skin that forms as a result of the healing process related to an injury or a lesion. The example of a scar that the textbook gives us is like a post-operative procedure. Maybe your client had a knee surgery, wrist surgery, or any type of surgery that left behind a scar. And then lastly, for our secondary lesions, we have an ulcer. And again, you can see how ulcers affect the layers of the skin. An ulcer can affect the epidermis down to the dermis and even the hypodermis. As you can see there is a loss of skin depth. That is the characteristic of an ulcer. It's an open lesion. We can have ulcers on the skin, but you can also have ulcers on mucous membranes of the body. They're usually accompanied by loss of skin depth and possibly weeping of fluids or pus from that area. These require medical referral, particularly in clients with underlying medical conditions such as diabetes. Examples of ulcers that the textbook gives us is chickenpox and herpes. All right, so objective number 4, we're going to recognize skin changes that could indicate a type of skin cancer. So skin cancer risk increase with cumulative UV sun exposure and is found in 3 distinct forms that vary in severity. Each form is named for the type of cells that are affected. Skin cancer is caused by damage to the DNA. Early detection is always best, and if detected early, these abnormal growths can be removed, and if not taken care of, they can be deadly. Here are just some fun facts or interesting facts about skin cancer and sun exposure. So about 91,000 new melanomas will be diagnosed every year. Skin cancer is the most common cancer diagnosis for men over the age of 50. About 9,320 people are expected to die of melanoma each year, and more than 90% of skin cancer is caused by sun exposure. Non-melanoma skin cancer is caused by UV rays from the sun. Another interesting fact is that 1 person dies from melanoma every hour. 1 in 5 Americans will be diagnosed in their lifetime with skin cancer. And then I also found this interesting that 1 bad burn in your childhood can double the risk factor for melanoma later in life. Also, a blistering sunburn during childhood increases the risk of melanoma as an adult, and melanoma is the deadliest form of skin cancer. Skin cancer kills more women in their late 20s and early 30s than breast cancer does. And then there is a 75% increase of melanoma risk among those who use tanning beds in their teens and 20s. Using sensitivity and concern with your client will help you to suggest when it's time for your client to seek medical attention. So if you find that you need to refer your client or you're concerned about changes in their skin, you can simply say, hey, I'm concerned about this area on your forehead. Before I do any treatment on it, I need you to see your healthcare provider for an evaluation. I'll perform your service today and avoid this area. Okay, so Clients will appreciate your concern and know that you have their best interests at heart. So let's talk about actinic keratosis. So an actinic keratosis is a pink or flesh-colored precancerous lesion that feels sharp or rough and is a result of sun damage. It should be checked by a dermatologist. So make sure that you add this to your notes. Actinic keratosis, they are precancerous lesions, usually pink or flesh colored, and they also feel rough or sharp. There are 3 types of skin cancer. A lot of times we use our moles to detect cancer. So a normal mole is going to be a small brownish spot on the skin that may range in color from like a pale tan to a brown or possibly even bluish black. Please note that moles are not skin cancer. However, if you have a change in your moles, then you need to get them checked for skin cancer. So let's talk about the first type of skin cancer. The top right picture, that is an example of basal cell carcinoma. So this is the most common and least severe type of skin cancer, which often appears as light pearly nodules. Characteristics may include sores, reddish patches, or a smooth growth with an elevated border. Okay. The next type of skin cancer is squamous cell carcinoma. So this is the picture in the bottom left corner. So this was more serious than basal cell carcinoma. It's characterized by scaly, red, or pink papules or nodules. It also may appear as open sores or like a crusty area on the skin. And this one can grow and spread in the body, okay? And then the bottom right, the darker one, is an example of malignant melanoma. This is the most serious form of skin cancer, as it can spread pretty quickly, or it can metastasize very quickly. It may have black or dark patches around the skin and are usually uneven in texture. The border may be jagged, or it also may be raised. Some melanomas may have surface crusting or may even bleed. Malignant melanoma is the least common, but it is 100% fatal if you leave it untreated. So notice these differences or changes in your skin and your client's skin, and make sure that you refer your clients at the first sign or first thought of you observing something that is abnormal. Oncology aesthetics is a medical niche that has emerged in the recent years. Oncology is the medical study of cancer and its treatments. So treating skin that has been exposed to radiation and chemotherapy requires a depth of knowledge beyond aesthetics. The skin can be much more fragile, also much more reactive after a person has gone through cancer treatments. So again, that's why extended training is going to be best if you want this to be your niche. Additionally, you do not want to provide any services or any treatments or skincare products that could be contraindicated to their cancer treatments. So that's just our little tidbits about oncology aesthetics. Clients with skin cancer still need the healing benefits of touch and can additionally benefit from skincare treatments that are soothing and calming. Here are the ABCs of melanoma detection, because melanoma, again, is the most severe type of skin cancer. So the American Cancer Society recommends using the ABCDE skin cancer checklist to make potential skin cancer easier to recognize. And so when you're checking existing moles, you want to look for changes in any of the following areas. So if there's been a change to asymmetry, which is what the A stands for, the two sides of the lesion are not identical, then you may want to get checked out. The border, if the border is irregular on the lesions, you may want to get that checked out. If the color starts to change, melanomas are usually dark and have more than one color or fades into another color. If you notice that, refer your clients or yourself to a physician. If the diameter changes, Let's just say that it grows in size, or at least to the size of a pencil eraser, then you want to get that checked out. And then again, if this mole is evolving, if it's changing in appearance, you want to get that checked out. Remember, early detection is the best. So let's get into objective number 5. Describe the types of acne. So acne is an inflammatory skin disorder of the sebaceous glands. Add that to your notes. It is an inflammatory skin disorder of the sebaceous glands. It is medically known as acne simplex. Add that to your notes. It's known as acne simplex, or it's also known as acne vulgaris. Add that to your notes. If you're following along with your textbook, this is found on page 131. So, acne is characterized by excess sebum production. This excess oil and dead skin cells can plug pores, creating comedones, which are blackheads. They can also create papules, can also create pustules and cysts. This causes a growth of Propionibacterium acne, or what we call P. acnes bacteria. Now, the funny thing about bacteria in the follicles is that they are anaerobic, which means that this bacteria cannot grow in the presence of oxygen. So that is why anything that's going to oxygenate the skin is going to be great for your clients that have acne. Okay. So when follicles are blocked with sebum and dead skin builds up, oxygen cannot reach the bottom of the follicle. Hence, you have your acne breakouts. So your sebum can irritate the follicles and can cause inflammation. And as bacteria and inflammation grows, pressure is exerted on the follicle wall. If that wall ruptures, it becomes infected and the debris spills out into the dermis. Redness and inflammation is going to occur when that foreign debris is created from the dead white blood cells and is detected in the skin. And the white blood cells move in to fight the infection. So it's kind of like the cycle of acne. As far as papules, pustules, and cysts, know that papules are going to be red, they're going to be inflamed, and those papules are caused by that process. The papules may become more infected and pus may develop. If pus does develop, then that papule will turn into a pustule. And so pustules are filled with fluid from the dead white blood cells that fought the infection. And then cysts are nodules made up of deep pockets of infection. A lot of times you're going to find these underneath the surface of the skin. You may not be able to tell if there's a cyst just by looking at the skin, but once you start to observe the skin, touch the skin, do your skin analysis, you may feel cysts beneath the skin or in the deeper parts of the skin. And what happens is skin forms overhardened tissue around that infection to stop the spread of bacteria, which can lead to both depressed and raised scars from the damage of the dermal tissue. Because it's in the dermis, this variety of acne is typically called cystic acne. So if your clients have cysts beneath the surface, again, that is considered to be cystic acne and should be treated by a medical professional. So what causes clogged follicles? So acne is something your clients may have to deal with throughout their lives in various stages. It's important for you to understand the causes of acne treatments to better serve your clients. Your clogged follicles are basically caused by many factors, including excess oil, retention hyperkeratosis, so meaning retaining dead skin, okay, and also by sebaceous filament, so basically oil that's stuck in the pores, okay. Another reason for clogged follicles is that the opening of the follicle, which is what we call the ostium, is too small, and so the follicle may be too small to let any of those impactions out, which may lead to having clogged pores. Okay. I do want you to highlight what the term ostium is, O-S-T-I-U-M. That is basically the opening of the pores. Okay. So here we can see this person has comedones. Okay, we simply call comedones blackheads. Okay, um, it's a non-inflamed buildup of cells, sebum, and debris inside the follicles. An open comedone, again, is called a blackhead, and it's open at the surface and exposed to air, which is what causes that blackening on the surface. Because when the follicle is filled with excess oil, the blackhead forms and it's dark because it is exposed to oxygen and oxidation occurs. A closed comedone forms when the opening of the follicles are blocked with debris and white cells, or we refer to closed comedones as whiteheads. These should not be confused with milia, okay? Milia are something different, and we'll break those down in just a second. Sebaceous filaments are similar to open comedones. They're mainly small, solidified oil that's in the follicle that does not have like dead skin cells or dead cell matter. These filaments also block the follicle and can cause acne breakouts. A lot of times you're going to find filaments around or on the nose area. And then milia, again, they are small cysts. So that's the difference between a whitehead and a milia. Milia are firm white papules, and they are pearl-like masses of sebum and dead skin that does not have an opening. So just make sure that you're not confusing milia with whiteheads. Milia are going to be more common in your dry skin types, and they may form after some sort of trauma to the skin, such as like laser resurfacing or having chronic exposure to UV radiation. Also, sometimes newborn babies may get milia at birth or shortly thereafter. And again, they resemble small little sesame seeds, and they're always mostly perfectly round. So it's going to be a difference between a milia and a closed comedone or a whitehead. And milia usually are found around the eye area, around the cheeks, or on the forehead. Okay, so they can be caused by blocked follicles. And then if you need to treat milia, milia can be treated by increasing exfoliation or using a retinol product to thin the stratum corneum. And then you can also use your extraction tools to extract milia as well. If they don't pop out, if you're not able to get rid of them, then just leave them alone. Over time, with regular cleansing and exfoliation and retinol application, the milia should go away. Other types of clogged follicles are things like retention hyperkeratosis. Now, I do encourage you to go look this up to research some pictures of what retention hyperkeratosis may look like, because the textbook is not giving us examples of what it looks like. But retention hyperkeratosis, it is a hereditary factor in which dead skin cells build up because they are not shed from the follicles as they do on normal skin. So basically, people with retention hyperkeratosis, their skin doesn't shed like normal. Okay, so they need products and treatments that's going to help exfoliate their skin. Sebaceous hyperplasia is another type of clogged follicle. This one involves benign lesions frequently seen in oilier areas of the face. They're often white, yellow, or even flesh colored, and they're described by a donut shape with an indentation in the center. So if you ever see a donut shaped lesion on the skin that has a flat center, that is going to be sebaceous hyperplasia. Again, I encourage you to go research a picture of what this looks like so that you can have a better idea, because the text does not give us one. And then what happens with sebaceous hyperplasia is that as the cell turnover rate slows with age and androgen levels decline, it causes an abnormal cell buildup with very little oil that crowds or enlarges the sebaceous glands. So don't mistake these overgrowths of the sebaceous glands for comedones or milia, which may look similar at first. These are definitely harmless lesions, but you cannot remove these by extractions. The only way to get rid of sebaceous hyperplasia is by cryotherapy, surgery, or laser. And then we have seborrhea. It is a severe oiliness of the skin, and it's an abnormal secretion of the sebaceous gland. When it's in the scalp, it's called dandruff or seborrheic dermatitis, but it can occur around the eye, the eyebrows, behind the ears, around the nose, or other areas of the face. Seborrhea is not acne. Okay, so although the inflammation in the skin from seborrhea can be misidentified as acne, it is not acne. All right, so let's break down the grades of acne since we're discussing it so much. So you can find this chart on page 134 of your textbook. So acne is graded on a scale of 1 to 4. Grade 1 acne is mild and usually treated with over-the-counter skincare, whereas grade 4 has progressed to consistent breakouts and deep cysts that requires medical intervention. So I do want you to make sure that you write down the characteristics of all 4 grades of acne, because you'll see these. You'll need to know these. You'll need to be able to identify these and consult with potential clients and your clients who may develop acne. So grade 1. For clients that have grade 1 acne, you're going to notice a very minor breakout, mostly open comedones, so mostly blackheads. They may have some closed comedones, so some whiteheads, and maybe a few papules. Not very many pustules. Your grade 2 is going to be a little bit more intense. Many closed comedones, many open comedones, so many blackheads, many whiteheads, and then you're going to see an occasional papule and pustule. So the breakout is going to be slightly more severe than the grade 1. Your grades 3, you're going to see some inflammation with these guys. So you're going to see some redness in the skin, many comedones, so many blackheads, many papules, many pustules. But you won't feel any cyst beneath the skin surface. That's what takes us into grade 4. So grade 4 is going to be the most severe. We call this cystic acne. A lot of times people that have grade 4 acne end up developing acne scarring. Cystic acne or grade 4 acne is characterized by cysts with comedones. So cysts with some blackheads, whiteheads, papules, and pustules. You're going to see some inflammation. And again, you're going to see some scar formation from tissue damage, which is very common in your grade 4 acne. Some acne triggers include genetics, your hormones, and your environments. Also, lifestyle, certain products and dietary influences also affect acneic breakouts. So during the consultation, you can ask questions about each of these subjects and learn more to better develop a treatment plan to help your clients. So make sure you ask about your genetics. Hey, does mom, dad, anybody in your family suffer from acne? Did you notice acne after you hit puberty, or are you in this stage of life where your hormones are changing? What does your lifestyle look like? Do you work in a greasy environment, in a polluted environment? Do you live in a polluted area? Things like that. If your client's parents had acne during puberty or any other time, or whether or if other family members have acne, treatment for genetic acne, it's not, for one, there's not a cure for acne, but just understanding the fact that if it's genetic will help you to better treat them. So what you can do is just try to help your client get their acne under control. You can do a comprehensive approach that addresses the skin holistically, and ultimately help your client experience the best improvements within their skin. But you need to understand why your client, what you can do to help their client, help their breakouts. If your client's acne is due to hormones, it's happening because of the androgen fluctuation, the hormonal fluctuation during puberty, during the monthly menstrual cycle, or hormone surges. Pregnancy, also perimenopause, can contribute to oil production changes that can bring about comedones, papules, and pustules. Um, Premenstrual water retention can cause slight swelling, enough to influence the epidermis and block the pilosebaceous unit. So during your consultation, you may have to dig a little bit deeper to get a better understanding of um, hormonally induced acne. You may suggest that your client seek medical help or a medical professional to change their birth control prescriptions if the acne developed when the client started on the pill or any type of IUD. So you might want to know if your client is taking any type of birth control, because sometimes that can affect the breakouts. And then treatment options for hormonal acne. A lot of times you're going to do well with including additional exfoliation to help keep that stratum corneum thin so that the oil can escape the surface more easily. So this may include you performing things like chemical peels on your client, maybe enzyme treatments or enzyme peels, offering microdermabrasion options to them. Also, their home care products can include an antibacterial cleanser. You may have them to use a salicylic acid-based product that's lipophilic, which basically will eat up or penetrate the oil and dissolve the oil. And then as far as moisturizers, you want to have them on something lighter. So water-based moisturizers are going to be the best for them. And I was going to say something else about if you're going to prescribe salicylic based treatments to your client, just make sure that they don't have an allergy to aspirin. If the environment is the cause, okay, maybe they're working in a place that has a poor air quality, lots of pollutants, or comedogenic exposure. These can typically increase inflammatory responses of the sebaceous glands. And dramatic climate changes, including changes of the season, humidity, and temperature will influence oil production. So understanding your client's work environment is another aspect of the puzzle that you'll be solving to help your clients with acne. So ask your client, do they work around oils, chemicals, grease, or ink? And does your client work in an area that has poor air quality? Treatment for environmental influences. You just want to encourage your clients to cleanse their face at the end of each workday to remove any residual pollution, oil, grime, or other pore clogging factors, so that you can improve the quality of their skin. Also, occlusive products may be too heavy and trap bacteria, so treatments that exfoliate as well as oxygenate the skin can help. So the P. acne bacteria cannot live in the environment with rich oxygen. So also performing services like high frequency or oxygen treatments will be great for those clients. Lifestyle triggers can also contribute to acne. So stress can stimulate the adrenal gland and produce more hormones, which leads to more oil production. So did your client recently start a new job, or did they lose employment? Did they have a romantic breakup, or did they recently get engaged or married? Has there been a death in the family, a loss of a loved one or close friend? Did they move to a new home or new town? Those are some questions that you can ask about lifestyle, because sometimes lifestyle can affect or influence acne breakouts. Also, pressure or friction from the cell phones, along with wearing hats or scarves or other devices where that object routinely touches the face, can also transfer bacteria to the face and induce a breakout. Fragrances from dryer sheets, laundry detergent, shampoos can also cause sensitivity and a breakout. So in terms of lifestyle influences, suggesting lifestyle changes to your clients can help them find the triggers that stimulate an acne breakout or acne flare-up. Sometimes it can be just a simple fix, such as more frequent changing of their pillowcases, cleaning their cell phones, and things like that. Cosmetic and skincare products can also be a cause or trigger to acne. Certain products and ingredients can aggravate acne. So just know that any fatty ingredients, such as like anything that's a wax, also some oils can clog or irritate the follicles. Um, these are considered to be comedogenic. And so comedogenic ingredients basically block follicles, which can cause cell buildup, resulting in having blackheads or comedones. So products rich in emollients or products that are occlusive, that are too heavy for the skin, can make your client more prone to breakouts. So moisturizers and sunscreens with lighter formulas are going to be your best option. So you want to do oil and water emulsions instead of water and oil. You want lighter products. Many makeup products are comedogenic, but you want to just have a discussion about makeup, have a discussion about their brushes, make sure that they're cleaning their makeup brushes, not wearing comedogenic makeup. And yeah, that's pretty much it as far as cosmetics. And then lastly, as we know, diet can be a major trigger for acne. So just educate your clients on their diet and how their diet can influence their acne breakouts. So there is an increased number of studies that are linking food allergies or sensitivities to acne. So foods with higher glucose index, sugary things, processed foods, foods that have heavy iodine content like shellfish, also dairy, are going to be contributors to acne. Although the relationship is not fully understood, research shows that these things do contribute to acne flare-ups. So if you're treating a client's acne for dietary influences, just remember that you're not a nutritionist or dietitian, but you can encourage them to eat a healthy diet, drink plenty of water. The more water you drink, the better your skin will look. The better you eat, the better your skin will look. Okay? In terms of medicated treatment options for acne, so regular skincare sessions with exfoliation and incorporating modalities like high frequency microdermabrasion and chemical peels can help keep the stratum corneum thin, so that keep that outer layer of the skin thin, to help keep oil production under control and add hydration and oxygenate the skin to eliminate bacteria. Um, you can also have a collaborative approach with a medical professional like a dermatologist. Your clients may see a dermatologist and you as an esthetician, and there may be a variety of treatments from topical antibacterial agents to eliminate P. acne bacteria. Um, the dermatologist may prescribe antibiotics. It may be oral, or it could also be topical. And there is a list of common acne medications or acne treatments that are prescribed by a dermatologist. So you want to make sure that you understand what your clients are used or have been prescribed. So on your intake forms, if you see that they've been using adapalene, which is different, like a different gel, azelaic acid, any kind of birth controls, clindamycin, isotretinoin, spirulactinone, Tesseract, or Retin A. These are all common acne medications. Please familiarize yourself with this chart on page 137, so that you understand the potential side effects and the actions. But in general, these and here are these medications. So again, adapalene, azelaic acid, so Azalex, if you see them right there on their intake form, birth control, clindamycin, isotretinoin, spironolactone, Tazarac, or Retin A. Again, these are going to be medications that are prescribed by a dermatologist, and you just want to familiarize yourself with the actions and potential side effects. Overall, all of these medications are going to be drying to the skin. Some of them even thin out the skin. So if your client is taking any of these medications, you just want to make sure that you're doing your diligence in knowing how they affect the skin and knowing what you should and should not do to your client's skin if they are using any of these medications. Other considerations for medicated acne treatments. For one, you cannot cure acne, but you can help control the breakouts. So doing things like recommending the best home care products, including ingredients that have benzoyl peroxide or vitamin A, is going to be great for your clients. Remind your clients that treating acne and getting it to have a better appearance does take time. You can also give them information about acne so that they can better understand what's going on with their skin. You also want to make sure that your moisturizers and serums that you're recommending for home care treatments, they are low on the comedogenic scale, so things that are not going to be occlusive to the skin. Again, benzoyl peroxide products are going to be often combined with topical antibiotics. That's just going to help to reduce developing antibiotic resistance. So your client may use both. They may alternate using benzoyl peroxide with vitamin A or antibiotics. When it comes to using vitamin A products, you want to recommend that they use those products in the evenings because they are photosensitizing. And again, a very small amount of any vitamin A product usually goes a long way. You may also, with your vitamin A derived products, have your clients use them maybe every other day or maybe every 2 days until they get used to using those products, because you do have to, a lot of times, build up the tolerance for various vitamin A products. Again, salicylic acid and azelaic acid are both antibacterial, which are great for clients that have acne. Salicylic acid is lipophilic, which means it's going to digest sebum and help to reduce that oil production. Birth control pills and other medications, oral medications, may be provided to your clients by their dermatologist to help suppress their acne breakouts. Next, we have Objective 6, which is describe the symptoms of polycystic ovarian syndrome. So we also call this PCOS. We shortened that term as PCOS. PCOS is a hormonal condition that affects 1 in 20 women in their childbearing years. Symptoms include increased androgen production that causes development of cysts on their ovaries. The cyst creates irregular menstrual cycles and difficulty with fertility. Clients with PCOS are insulin resistant and have challenges with weight loss a lot of times. Sleep apnea is also a symptom. Clients will work, the esthetician will work with clients who have PCOS because sometimes their PCOS symptoms include acne. In addition to having acne, they may have thinning hair. They may have male pattern baldness, which is a sparse hair density at the front and top of their head. They also may experience abnormal hair growth on their face, arms, thighs, neck, and breast. So PCOS is not a condition that can be cured, but like acne, we can, try to manage the symptoms. A lot of times your clients with PCOS, they are put on birth control pills to regulate the sex hormones and also androgen blocking medications that can help control their hair growth and acne issues. As an esthetician, you may perform hair removal treatments for them, such as waxing, laser services, maybe even electrolysis, and then you may perform skincare treatments using ingredients that encourages that corneal layer of the epidermis to be thin. So that's our spiel about PCOS. I do encourage you to do more research, but the main thing in our treatment room that we may be treating our clients that have PCOS is more than likely going to be like acne or maybe abnormal hair growth. Okay, so let's get into objective number 7, which is list common vascular conditions or disorders. Vascular conditions and disorders can be hard for a client to deal with, so it's important to understand the types to better help your client. So the first vascular condition is rosacea. So rosacea is an inflammatory and vascular disorder with multiple causes that are not completely understood. It is a progressive disorder that starts with just simple flushing and increasing bouts of redness. Visible vessels and skin sensitivities are also symptoms, and then the symptoms can progress to pustular type breakouts that can be confused with acne. Rosacea can affect the eyes as well, causing like chronic bloodshot eyes, some clear or yellowish discharge and irritation. And in advanced cases, rosacea can cause the skin to thicken, particularly around the nose area. And so this symptom is called rhinophthalmia. So rosacea can be challenging to treat because it's unclear of its origin. So causes may be hereditary, it may be bacteria, also the Demodex mite and fungus are all possible theories about rosacea. Certain factors are known to aggravate rosacea, and vasodilation of the blood vessels, meaning like the opening of your blood vessels, do make rosacea worse. So eating spicy foods, drinking alcohol, caffeine, and extreme temperatures, extreme heat, overexposure to the sun, and stress can all aggravate rosacea symptoms. So I would definitely jot down what aggravates rosacea and what it is. So basically, it's an inflammatory condition. It can be exacerbated by spicy foods, alcohol, caffeine, extreme temperatures, heat or cold, and also stress. Um, as far as treatments for rosacea, just like acne, estheticians, we can treat the symptoms, but we can't cure it. And so you may be in collaboration with a medical professional, but antifungal prescription skincare products may help those clients. Also, in your treatment room, you want to just use calming ingredients and treatments that will help decrease inflammation. Also, providing soothing facials with gentle massage and very light exfoliation. For your clients with rosacea, you want to limit the use of steam. And you can also add high frequency to help oxygenate the skin to help. And then other advanced treatments and aesthetics may include like laser, IPL, and radio frequency. Those can help with your rosacea clients. Next, we have the term telangiectasia. So telangiectasia is basically visible capillaries. They're small, so anywhere from 0.5 to 1 millimeter in diameter, commonly found on the face, particularly around the nose, the cheek, and the chin. They can appear due to an injury, hereditary, rosacea, hormonal changes, or exposure to extreme cold or heat. And what happens is it's just a matting of any tiny telangiectasia can create a ruddy complexion in your clients. I mean, meaning like a reddened complexion in them. We also call that cuprose skin. So you might want to jot that down. And telangiectasia is a cosmetic irregularity. It's not a medical condition. It's just something that happens. And then we have varicose veins. Varicose veins are the last type of vascular condition that you may observe on your clients. As an esthetician, I doubt that you treat these, especially not in Texas, but these are basically like dilated and twisted veins. Often we're going to find these on our clients' legs, can be caused by pregnancy, extended periods of time standing or sitting, can also be caused by genetics as well. They use sclerotherapy as a treatment. So basically, they inject a solution into the vein, which is called sclerotherapy, to collapse those veins, making them to appear smaller. So that's pretty much all that we have for rosacea. If you want to read more on that, you can find it on page 141 in your textbook, or go down the rabbit hole with your own research. All right, so we have objective number 8, which is identify pigment disorders. So The genetic background of a person influences their pigment disorders if they have them. Abnormal pigmentation is also referred to as dyschromia. Okay, and dyschromia can be characterized by hyperpigmentation or hypopigmentation. So I would definitely add both of those to my notes if you're taking notes, which I highly recommend. Also, play this video back as many times as you need to. Pause it as much as you need to make sure you're getting thorough notes. So, hyperpigmentation. It's an overproduction of pigment, and hypopigmentation is lack of pigment. And these are the two types of pigment disorders. Sun exposure is the biggest external cause of pigment disorders and can make existing pigmentation disorders worse. Drugs may also cause certain pigmentation abnormalities as well. And main causes of these disorders are sun exposure and drugs. So let's break down the different types of pigmentation. So the first one we have is melasma. So the top left picture would be an example of melasma. It's a type of hormonal pigmentation disorder that appears during pregnancy or with the use of birth control pills. And melasma has an identifiable pattern of solid, fairly symmetrical hyperpigmentation on the forehead, the cheeks, upper lips, and chin. Sun exposure can exacerbate the pigmentation of melasma, so a person may have melasma and sun damage. As far as addressing the symptoms of melasma, it can be challenging as an esthetician. The pigmentation can fade during times of low UV exposure by your clients. Also, when their hormones return to normal levels after pregnancy, that usually will alleviate that pigmentation. So a lot of times, melasma is also called pregnancy mask. So as soon as a woman's hormones go back to their normal levels, the pigmentation goes away. You can also treat your clients with melasma with melanocyte inhibiting skincare products or tyrosinase inhibiting skincare products. You also want to recommend that they use sunscreen as often as possible. You can also perform chemical peels for these clients as well. Just know that melasma is a condition that requires management. There is no cure for melasma. Next, we have lentigo, which is characterized as a flat pigmented area similar to a small freckle. They may be small yellow-brown spots. Our top right picture is our example of lentigo. And they're just multiple pigmented lesions. A lot of times we call them age spots. So medical professionals identify lentigines that result from sunlight exposure as actinic or solar lentigines. So again, they're usually associated with age spots. That's what we usually call those. The bottom left is an example of ephelids, also known as freckles. Okay, so they're tiny, round, or oval pigmented areas of skin on areas exposed to the sun. They may also be referred to as macules, which are small, flat-colored spots on the skin. And then a nevus, which is this bottom right picture. A nevus is nothing but a birthmark, okay? So a birthmark is considered to be a pigment disorder. And what happens with birthmarks is it's a malformation of the skin from abnormal pigmented or dilated capillaries that present at birth or appear shortly after birth. A port wine stain is also a vascular type of nevus, so that would fall under that category as well. Okay, if you look at the picture at the top, so you can see that there's some pigmentation there. That is, actually, that is not a picture of poikiloderma of Shabbat. I do want you to look up poikiloderma of Shabbat because the textbook does not give us the example. Milady, help us. All right, so poikiloderma of Shabbat is basically a skin condition that's caused by actinic bronzing. So if you've ever seen someone that has like bronzed skin and they're lighter complected but their skin looks bronzed, is due to chronic sun exposure. It is poikiloderma of Shabbat. You may find it on both sides of the face and even on the neck. So the skin, what happens is it turns like a reddish brown hue with a distinct white patch under the chin. Poikiloderma is benign, meaning it's not cancerous. But the treatment can be combined with melanocyte inhibiting skincare, chemical peels, advanced treatments like laser and IPL, consistent sunblock use, and avoiding any kind of irritants such as heavy fragrances on the skin. And then the picture at the top here, you see how she doesn't have any breakouts, but she has some left behind pigmented spots on her face. So that is what we call post-inflammatory hyperpigmentation. Post means it comes after, right? So it's a darkening pigmentation due to an injury of the skin or from the residual healing after like an acne lesion breakout has resolved, and it usually looks like, deep purple, reddish, or brown appearances on the skin. That is our post-inflammatory hyperpigmentation. So it can come after a burn, can come after acne breakout. It can come it can appear on the skin if you do extractions incorrectly and you damage or create trauma to the skin. Okay. And then a tan, I don't think I need to break a tan down, guys. A tan is just a result from sun exposure, okay? Tanning changes the pigmentation in your skin because of the exposure to UV, okay? So basically a tan is visible cell damage, okay? Now let's get into hypopigmentation. So hypopigmentation occurs in various forms. It is seen less commonly than hyperpigmentation disorder. The first term I want to cover is leukoderma. So leukoderma is basically a loss of pigmentation that leading to light abnormal patches of depigmented skin. It is a congenital disorder acquired due to immunological and post-inflammatory causes. So vitiligo and albinism, they both fall under leukoderma. They are types of leukodermas. For albinism, if a person is albino, they are suffering from a rare genetic condition that's characterized by a lack of melanin pigment in the body, including their skin, their hair, and their eyes. So this person is at risk for skin cancer, and they're also sensitive to light and ages early without normal melanin protection. The technical term for albinism is congenital leukoderma or congenital hypopigmentation. Then we have vitiligo, which is a pigmentation disease characterized by white, irregular patches of skin that are totally lacking pigment. This condition can worsen with time and sunlight, and the disease can occur at any age and is believed to be an autoimmune disorder causing the absence of melanocytes. Then we have tinea versicolor. Tinea versicolor is basically caused by a fungus or a fungal infection of the skin. A lot of times it's also referred to as pityriasis versicolor. And again, it's a fungal condition that inhibits melanin production. It's not contagious because it is caused by a yeast, which is a normal part of the human skin. But it's characterized by white, brown, or salmon-colored flaky patches on the skin. Sun exposure can stimulate the growth of the fungus, and this fungus can be treated with antifungal creams or other medications. Selenium sulfide shampoos can be used to treat the condition, and anti-dandruff shampoo can also be used. High humidity and summer heats do stimulate the condition, and it usually fades or goes away in the cold winter seasons and reoccurs in the warmer weathers. All right, so objective number 9, dermatitis. Describe the different types of dermatitis. So what dermatitis is, and do add this to your notes. It is a generalized term to refer to an inflammatory condition of the skin. So dermatitis is nothing but a skin inflammation. Various forms include lesions such as eczema, vesicles, or papules. Dermatitis has many forms, and symptoms of one form can be confused with symptoms of another. So let's talk about contact dermatitis. So occupational disorders from ingredients in cosmetics and chemical solutions can cause contact dermatitis, or what they call dermatitis venenata. So contact with allergens or caustic chemicals. When I say caustic chemicals, it's like alkaline chemicals, okay, can cause sensitivities, skin sensitivities and disorders. So wearing gloves and protective skin creams while working with chemicals or irritating substances can help prevent contact dermatitis. Then there is a such thing as allergic contact dermatitis. That just means that you've come into contact with something that you are allergic to. Okay, so an allergic reaction occurs when our immune system makes mistakes. Mistakes a benign substance for something that's toxic and immediately goes into defense. That just means that you're allergic to it. Okay. We also can develop hypersensitivities to certain things by repeated exposure to an allergen over time. So sensitization, that process is called sensitization, and sometimes it may take months, it may take years, or it may even just take a few days. So just be mindful of protecting yourself when working with chemicals and different products and ingredients. Common allergens that that help people develop dermatitis, maybe like makeup. It could be some skincare products, different detergents, certain dyes, certain fabrics, red dye in some products, nickel in some jewelry, jewelry in general, different plants can all lead to dermatitis. Atopic dermatitis, which you need to add to your notes, is a chronic relapsing form of dermatitis. And atopic just means excessive inflammation from allergies. So irritants and allergens trigger reactions that include dry, cracked skin. The redness, itching, and dehydration of the dermatitis makes the condition worse. So use of things like humidifiers and lotions can help keep the skin more hydrated. Topical corticosteroids can also alleviate the symptoms. Eczema is also a form of dermatitis if you didn't know that. So eczema is an inflammatory, painful, itching disease of the skin. It can be acute or chronic in nature, and it also can be dry or moist. And then a client with eczema should be referred to a physician, and you just want to avoid contact and skincare treatments if that client has eczema. And then irritant contact dermatitis just means that that you've come into contact with something that's irritating your skin. So everyone who comes into contact with an irritant is affected by irritant reaction, although the degree of the irritation will vary depending on the individual. Symptoms can range from redness of the skin, some swelling, some scaling, and some itching, to serious painful chemical burns. So irritating substances temporarily damage the epidermis. Again, caustic substances, those alkaline substances, are examples of irritants. And so when the skin is damaged by those irritating substances, the immune system again springs into action, and it floods the tissue with water, trying to dilute the irritant. Therefore, swelling occurs. Also, the immune system releases histamines, which helps to try to fight that allergy or the irritant. And so there may be extra blood under the skin, which may lead to the area becoming red and warm, or maybe even thriving. Okay, histamines do cause an itchy feeling that often accompanies contact dermatitis. And everything usually calms down, and swelling will go away once that irritant is removed from the area. Perioral dermatitis is an acne-like condition around the mouth consisting mainly of small clusters of papules. It may be caused by toothpaste or other products used on the face. It's not contagious, and antibiotics can usually help treat those conditions. Seborrheic dermatitis, um, which is the bottom right example on the bottom right. Okay, it's a form of eczema that's characterized by inflammation, dry or oily scaling or crusting, and or itchiness. The red flaky skin often appears in the eyebrows. You may see it on the scalp, along the hairline, in the middle of the forehead, or along the sides of the nose. One cause is inflammation of the sebaceous gland, and this condition is sometimes treated with cortisone creams. Okay, and then more severe cases are referred to a dermatologist. And then we have stasis dermatitis, which is caused by poor circulation in the lower legs that can create a chronic inflammatory state. So legs may have like ulcerations along with scaly skin, itching, and hyperpigmentation. So a client that's dealing with this disorder may need a cardiovascular referral because there's something going on with their blood flow. Okay, objective number 10, identify the type of hypertrophy. So hyper just means excessive. So hypertrophy is defined as an abnormal growth. Many are benign, which means that they're harmless. However, some growths are premalignant or malignant and can be dangerous or cancerous. So the term hypertrophic is used to describe the thickening of a tissue. The opposite of hypertrophy is atrophy, which means wasting away or thinning. Okay, so here we're talking about hypertrophies of the skin. So we're talking about excessive growth of the skin. The first type of hypertrophy of the skin is called hyperkeratosis. Okay, hyperkeratosis is defined as an abnormal growth. Is characterized as the thickening of the skin caused by a mass of keratinocytes. So basically, a mass of dead skin cells. Then we have a keratoma. If you've ever heard of a callus, on the low end we call it a callus. On the high end, it's called a keratoma. And basically, it's characterized by an acquired thickened patch of epidermal of the epidermis. And then a callus is caused by pressure and friction. Okay, that's what a keratoma is. So anytime a person develops a callus, that's because they've had continued pressure or friction on that area. Also, if the thickening grows inward, it becomes a corn. So if you've ever heard of a corn, a lot of times people will get corns on their toes, maybe sometimes on their knuckles. So corns and calluses are both keratomas. One thickens on the outside, which will be a callus. Corns, they thicken inwardly. And then we have keratosis. So keratosis is just an abnormally thick buildup of skin cells. Okay. Then we have keratosis pilaris. We do have an example. This top picture is an example of keratosis pilaris. A lot of times people call it chicken skin. So it's redness and bumpiness of the skin. A lot of times it's found on the cheeks, the upper arm area, sometimes on the thighs. And the cause of keratosis pilaris is blocked follicles. And again, like I said, it usually appears as like chicken skin. And usually for this one, topical exfoliants work well. So chemical peels, alpha hydroxy acids, beta hydroxy acids will work. Light mechanical exfoliation, scrubs will work. Microdermabrasion may also work. Just be careful not to get too aggressive in the approach because you don't want to disturb the acid mantle and cause any type of dermatitis or infection. All right. A mole. Yes, a mole is a hypertrophy. Okay. It's a pigmented nevus. A lot of times it's a brownish spot ranging in color from tan to bluish black. Some moles are flat, some of them are raised, some of them resemble freckles. Most moles are going to be benign, but again, like I discussed earlier, any changes to the color or shape, you want to get those checked out by a physician. Then we have psoriasis. So this bottom left picture is an example of what psoriasis looks like. I want you to write down psoriasis, and I want you to write down white silver scales or white silvery scales. I promise you're going to see that on your state board exam, especially if you're in Texas. They find a way to throw that in there somewhere. They want to make sure that you at least know what psoriasis is. So psoriasis is an itchy skin condition characterized by red patches covered with white silver scales. And it's caused by an overproliferation of skin cells that replicate too fast. So psoriasis is usually found in patches on the scalp. Other common places are going to be elbows, the knees, the chest or lower back. So those are going to be common places that you'll find psoriasis. If the patches are irritated, bleeding can occur. Psoriasis is not contagious, but can spread by irritating the affected area. It is thought to be an autoimmune disorder, and clients experience flare-ups that can be controlled by either oral or topical medications. Fun fact, light therapy is thought to be helpful for psoriasis. So clients are often diagnosed, they're also often diagnosed with a cardiovascular disease if they have psoriasis. And then lastly, skin tag. That's what this is down here, a little skin tag. It's a tag of skin that's hanging off. It's a skin tag is characterized by a small outgrowth or extension of the skin that looks like a flap. That's the definition. A small outgrowth or extension of the skin that looks like a flap. They are benign, meaning they are not harmful. You can commonly find these under the arms, sometimes on the neck, or in the breast area. A lot of times are caused by friction. So those are our hypertrophies of the skin. All right, guys, objective 11, and we only have 12. We got 2 more to go, and we'll be done. I know it's been quite lengthy. All right, so the term contagious disease is used interchangeably with the terms infectious or communicable disease. Do not perform services on anyone with a contagious disease because it can spread and infect others. Refer them to a medical professional. And here are some of the common contagious diseases that you may come across in the salon or spa. Coming in at number 1, we have conjunctivitis. On the high end, we call it conjunctivitis. On the low end, we call it pink eye. Okay. The definition is the inflammation of the mucous membrane or the conjunctiva around the eye due to chemical, bacterial, or viral causes. So it's 3 ways that a person can get conjunctivitis. It may be caused by chemical exposure, bacterial exposure, or viral exposure. It is very, very, very contagious. It can be treated with antibiotics if it is caused by a bacterial infection. Then we have herpes simplex 1. Okay, that's what you see on the top right. Now, herpes simplex 1 affects more of the population than we know. Okay, sometimes kids have herpes simplex. Maybe an adult kissed them or hugged them, or they got exposed when they were younger. So I don't want to say it's nothing to be concerned about because it's definitely contagious. But know that there is a difference between herpes simplex 1 and herpes simplex 2. Herpes simplex 1 is characterized by fever blisters or cold sores. It's a recurring viral infection, a vesicle or group of vesicles on a red swollen base. The blisters usually appear on the lips or nostrils. Okay, you can get cold sores in the nostrils. Herpes simplex 1 does cause cold sores and lesions around the mouth. It is contagious. It's a contagious disease that's treated with antiviral medication to shorten the outbreak. Now, herpes simplex 2 is a little different. This is genital herpes, okay? Never work on clients with active herpes lesions. No peeling, no waxing, and no other stimuli. in that area. It peels, waxing, and other stimuli may cause breakouts, even if the condition is not currently active. So you want to have that question on their intake form so that you can know what to do and not to do to your clients, and how to give them the best care and aftercare recommendations as possible. The virus can spread to other areas on the person that is infected or to other people. So again, this is why this is an example of why reviewing the client intake forms are important. Herpes zoster. If you've ever heard of shingles, shingles is a form of herpes as well. It's a painful skin condition due to the reactivation of the chickenpox virus. So if you've ever had chickenpox, you have been exposed to herpes zoster. Shingles is a viral infection of the sensory nerves characterized by groups of red blisters that form a rash that occurs in a ring or a line. Treatment includes antiviral drugs to shorten the length of the outbreak. And then we have impetigo, which is this bottom right photo. Sorry, that's not. We don't actually, let me see. I think the picture of impetigo may be on my next slide. So impetigo is a bacterial infection of the skin. It often occurs in children. It's characterized by small blisters or crusty lesions that's filled with bacteria. It is extremely contagious. Oral or topical medications or antibiotics are used for treatment. An untrained eye may misrepresent impetigo and assume that it's herpes or maybe acne or dermatitis. So again, professional medical intervention is the correct course of action for your client. And again, this top left one, that's what the text is showing us as an example of impetigo. Okay. All right, so then we have onychomycosis. So onychomycosis is characterized, the lady's using this bottom left photo of that nail as onychomycosis. So it's a fungal infection that produces thick, brittle, discolored nails. The fungus lives off the keratin in the nails, and clients with onychomycosis can feel embarrassed about the appearance of the nails and discouraged during a course of treatment because of slow nail growth. Estheticians could encounter this if you're doing body wraps or doing hand and foot massages with your facial, so just be aware of that. If onychomycosis is discovered, the facial service can be continued, but the esthetician should not continue with the hand or foot massage. Then we have tinea corporis, or that's tinea and tinea corporis. So just know that tinea is a fungal infection, so I do want you to write that in your notes. Fungi feeds on proteins, carbohydrates, and lipids in the skin. Tinea pedis is athlete's foot. So it's a fungal infection that can be treated with antifungal topical powders, sprays, or creams. So again, you may encounter tinea or tinea pedis, athlete's foot, if you are doing body wraps or hand and foot massages with your facials. So just make sure that you're reviewing the intake forms and also doing a good assessment of your client's skin before performing services on any part of the body. Tinea corporis. All right, tinea corporis is this top right photo. Okay. On the high end, we call it tinea corporis. On the low end, we call it ringworm. Highly contagious. Okay. It's caused by fungus, not a worm. It's caused by fungus and not a worm. I want to make sure I said that clearly. It does look like a skin irritation. It spreads into a circular infection and is red and scaly. Okay, it can be dry or it can be moist. It can be spread by direct contact as well as indirect contact with items that have touched the skin. That's why it's important to always protect your workspaces and your work areas. New sheets, new towels, new towels, new everything for each client. Protect your bed, protect your chair. There should be no client contact with any surface of your work areas. And you also want to make sure that you're cleaning and disinfecting your work surfaces and areas as well. Pets can also carry ringworm or tinea corporis. So that's just something to be aware of. So if you use blankets, towels, things like that, make sure you launder them properly. Wash them with hot water and bleach. These can be treated on your client's skin with any kind of oral or topical antifungal agents. And then at the bottom right on that finger is a wart. Okay. Low end we call it a wart. High end we call it a verruca. Okay. And it's a hypertrophy of the papillae and epidermis caused by a virus. So warts are contagious. They are viral. They are not cancerous, but they are very contagious. Okay. They typically are flesh colored, but can be black or brown. They can appear single by themselves, or it can be in clusters. So they can spontaneously disappear, but there are several treatment options. You can do cryotherapy, electric therapy, surgical removal, chemical exfoliation. So be aware of warts. Know that they are viral. It's imperative to wear gloves and not touch those areas or not treat those areas for your clients. All right. All right, objective 11, identify 2 mental health conditions that may manifest as skin conditions. All right, so the first one is dermatillomania, and it is a form of obsessive compulsive disorder, or OCD, in which a person picks at their skin to the point of injury, infection, or scarring. A person with dermatillomania finds the picking stress relieving and not painful. It can often be socially isolating because severe dermatillomania can be disfiguring. So treatment for this just includes cognitive behavior therapy, hypnosis, and medication, which is out of our scope, but this is just something to be aware of. Same thing with body dysmorphic disorder. So this is also a psychological disorder in which the client has a preoccupation with their appearance. They do not have a realistic picture of what they look like. They tend to be fixated on minor appearance imperfections and see them as disfiguring. They believe others are viewing them negatively because of their physical appearance. They may check the mirror more frequently and need an abnormal amount of reassurance that their appearance is acceptable. They may even be spa hoppers or have a history of cosmetic surgeries or treatments to fix their perceived flaws. They are dissatisfied with the outcome of treatments, so just be aware of these 2 mental health conditions. We are not a physician or a medical professional, so at the very least, we just want to be mindful and understand these 2 that we may come across in our treatment room. Alrighty, and then I think we are at objective number 12, which is recognizing common skin conditions related to skin diseases and disorders. So the skin conditions on table 4-6 on page 154 are often symptoms of more than one skin disease or disorder. Several of them may look very similar to another, and if you encounter these conditions, you will need to make an assessment and judgment about the treatments. Perhaps the condition is the result of an infection, or you want to ask is it the appropriate clinical endpoint of an effective treatment. So let's get into it. So a furuncle is a boil. We are not going to treat a boil. It's filled with pus. It's caused by bacteria in the glands or hair follicles. I recommend that you refer your clients to a medical professional to get those boils drained or removed. And a carbuncle is a group of boils, okay? So again, anytime the skin is red, inflamed, and you see pus is present, we are not going to work on those. Now, edema, you will see in your treatment room. Edema is basically swelling. So sometimes the client's skin may react and it may swell, but the swelling may go away. So just know that edema is just swelling from a fluid imbalance. It's a response from infection, injury, or medication. And then erythema, you may also see in your treatment room. You're going to see more erythema than edema. Again, edema just means swelling. Erythema is going to be redness caused by inflammation. So some services that we perform may cause your clients to have erythema. Massage will cause redness to appear on the surface. Chemical peels may cause slight inflammation. So just be aware of these terms. Folliculitis. That is basically when the hair grows under the surface of the skin instead of growing up. So basically these are like ingrown hairs. So just know that folliculitis is inflammation of the follicle and may also have ingrown hairs associated with it. So Barbe folliculitis is also a common thing. So with folliculitis, hair grows under the surface instead of growing up and out of the follicle, causing a bacterial infection. These ingrown hairs are common in men, usually from shaving. Okay, so it may be referred to as folliculitis barbae, barber's itch, Barbe folliculitis. Okay, and then pseudofolliculitis are known as razor bumps. Okay, so pseudofolliculitis are razor bumps. It resembles folliculitis but without pus or infection. Pruritus is the medical term for itchiness. Okay, so add that to your list. And then a steatoma is a sebaceous cyst or subcutaneous tumor that's filled with sebum. It can range in size from a small pea to an orange. These usually may appear on the scalp, on the neck, and on the back. These are also called a wen. So again, I'm going to refer you to page 154, and you can take a look at that table on page 4-6 that covers common skin conditions. All right, our last and final objective. We are here. Objective 13. We are going to explain the 5 sudoriferous gland disorders. The sudoriferous gland is our sweat gland. So let's hop right into it. The first one is anhidrosis. So anhidrosis is a deficiency in perspiration due to failure of the sweat glands. Often results from a fever or skin disease. Anhidrosis does require medical treatment. So again, if a person has anhidrosis, they are lacking sweat. They are not able to sweat like they should. Then we have bromidrosis. Like, bro, you stink. Okay, so that's an easy way for you to remember bromidrosis. So bromidrosis is foul-smelling perspiration, usually in the armpits or on the feet. And it's caused by bacteria and yeast that breaks down the sweat on the surface of the skin. Hyperhidrosis, remember hyper means excessive anything. So if we're talking about hyperhidrosis, that is chronic excessive perspiration caused by heat, maybe genetics, stress, or even medication. There are some treatments for hyperhidrosis or excessive sweating. So microwave technology, Botox, neuromodulators may help with that excessive sweating. Botox is the common treatment for that. Botox was not originally not supposed to treat wrinkles and fine lines. Botox is really formulated to treat migraines and to help with excessive sweating. Okay. All right. And then we have diaphoresis. Diaphoresis is just excessive perspiration due to an underlying medical condition like going through menopause. When women say they're having hot flashes, they're having diaphoresis. And lastly, we have miliaria rubra, which is also known as prickly heat. Okay. Miliary rubra is also known as prickly heat. It is an acute inflammatory disorder of the sweat glands. It results in an eruption of red vesicles and burning and itching from excessive heat exposure. So just simply recognizing a potentially contagious skin disorder can stop the spread of infection. You can formulate a more specific treatment plan and use the appropriate products when you can identify common skin disorders such as rosacea and acne, and understanding some skin disorders are contraindications for treatments will help you avoid negative outcomes. All right, that is all of our chapter 4 as a summary and review. With innovations from DNA, genetic research, and biotechnology advances, many new treatments and procedures are being developed to treat skin conditions. Reference books are helpful in identifying diseases and disorders, and conduct services in a safe environment and take the measures necessary to prevent the spread of infectious and contagious diseases. Follow your proper infection control is imperative in working with skin disorders. We hope that this review of chapter 4 has been helpful. If you have questions about anything, be sure to leave us a comment below and we will be more than happy to assist you. We wish you the best and good luck. Have a great day. Bye.